So, Dr. Jane Hata is the Associate Director of the Clinical Microbiology Laboratories at Mayo Clinic in Florida and Associate Professor of Laboratory Medicine and Pathology, Mayo Clinic Alex School of Medicine. Her responsibilities include technical oversight of the parasitology and molecular virology laboratories, including microbiological testing for the Mayo Clinical Laboratories Reference Service. She is a past member of the Microbiology Resource Committee for the College of American Pathologists and current chair of the Committee on Postgraduate Educational Programs for the American Society for Microbiology. Her research interests include diagnosis of fungal infections, development of molecular diagnostic techniques, and application of visual AI for the clinical laboratory. And so this is very skimpy. I know she does much, much more than this, but I will not embarrass her. So if you have any interest in the things she does, she would be more than happy to chat with you about any of those things. And without further ado, Dr. Hata.
Hold on, I'm doing AV things here.
Okay.
Technical difficulties.
Okay.
Actually, we don't need that. I can just,
Oh, okay.
Yeah.
I was gonna say it's really loud. So.
okay, I'll just talk.
Okay, Dr. Hata will be presenting body fluids microscopy, separating the trees from the forests.
Assuming I can get this to run. And so I'm going to go without this microphone. If you can't hear me in the back, start waving at me. You should be okay. 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 Happy New Year's, everybody. It's good to see everybody so far this year. Now, if you know me, you know that I'm usually saying something about molecular this or fungal that, and I'm going to change it up on you tonight. I'm going to do something completely different, which is good for all of us. I am going to be talking about body fluids of all things. So the question tonight is, how do we separate the forest of all the stuff that's in body fluids, and how do we parse out those important trees, the important pathogens that are in body fluids? So this is just going to be a nice review of things that you probably do every day. Maybe you haven't thought in depth about for a while, but I think you will get some enjoyment out of this actually. So here's my disclosures. And so we're going to focus on 4 body fluids for this evening's talk. We'll talk about cerebral spinal fluid, bronchoalveolar lavage fluids, peritoneal fluids, and synovial fluids. And so in all of that, I want to touch upon some pre-analytic steps that are very, very important. We'll get into processing workflows a little bit, but I want to focus on the key morphologic features inherent in each of these fluids. And of course, we'll talk about those important pathogens, those findings of note. And then very importantly, how do we make sure our ordering providers, our clients, if you will, understand the types of reports that we're putting out. And I want to spend just a little bit of time on formalin-fixed paraffin-embedded liquid cytology, because it was a methodology that I didn't know much about, but it's actually very cool. Okay, so let's first talk about pre-analytics. How do we get that specimen to us in the laboratory in one piece, ready to test? So, you know, these are just things that you need to look at and think about, and how it fits into your own workflow at your own institutions. We need a transport mechanism. So maybe you use a pneumatic tube system, maybe you have to hand carry. But in any case, if you're using a pneumatic tube, remember that sometimes we have those specimens that are irreplaceable. Sad fact is that tubes go awry. Sometimes they get lost, sometimes they break. And what are you going to do if you've got one carrying a precious specimen? Plan ahead. You may have to perform a risk analysis, especially if we have, say, a new pathogen and we have to worry about biosafety. So again, think about your workflows. Where, you know, how are we transporting? Where are we transporting? Who is transporting? And how do we do that safely? There will be situations where you may have large volumes of fluid. Certain tube systems do have a limitation on the amounts that they can carry. So what are you going to do? Plan ahead. If you're in a situation where you're having to hand carry, ask yourself, do you have the infrastructure to support it? Can you run 24/7? Can you transport once an hour, twice an hour, once a day? But again, you need to plan ahead and think about what is the best workflow to transport these body fluid specimens, because they are very important. Collection devices, lots of them. There are certain cases where if you're performing a particular test, it will specify a certain collection device be used. And that information is found in the instructions for use. If a laboratory chooses to deviate from that, you are going off label with the test. So again, consider the type of collection device that you'll need. Now, we know that sometimes supplies don't show up when they're supposed to show up, or there are shortages of things. We've all been through that. And so a laboratory may have to very quickly assess the market really for alternatives and validate those quickly. So again, think about these scenarios and what you're going to do to address them. And then finally, we have packaging. So we all know a lot about how to package specimens for transport, lots of regulations that we have to deal with, but also think about things like temperature stability and time stability, particularly if you are having to transport from your building on the other side of your campus or from an off-site collection place. And again, you know, maybe you have some unusual time and temperature conditions. You may have to validate those and do a study to indicate that your samples can indeed survive those conditions of transport. Okay, so let's get into the fluids. We'll first talk about cerebral spinal fluid. So this fluid's produced in the choroid plexus of the brain. Very important because it serves a cushioning function, so it keeps your brain from smacking into the inside of your skull. But it also is a metabolic fluid, so it clears out wastes from metabolism. It also provides nourishment for the various structures of the brain. The adult person usually has between 100 and 160 mils of CSF in their system at any given time. But given this metabolic turnover that takes place, we actually produce quite a bit, up to 500 mils per day. And of course, we know that our spinal fluid collections are via lumbar punctures, and they can be through artificial means such as ventricular cannula or VP shunts that might be implanted into a patient for various reasons. So, first question for the audience. You can just raise your hands. How many tubes does your laboratory collect for spinal fluid testing? Is it 1, 2, 3, 4? Something else? Have no idea. That's fine. There's no correct answer here. Well, actually, there is a correct answer here. So, according to CLSI, their guidance is to collect to 3 to 4 non-additive or non-gel sterile containers. Now, this does not mean a glass tube. Cells in the spinal fluid can stick to the walls of glass, and that will throw off your cell counts, so don't use glass. For this type of specimen, you're going to be splitting it, tubes 1, 2, 3, maybe 4. It's going to go to several different laboratory sections. Chemistry usually gets the first tube. Tube 2, that's for us, that's for micro. Tube 2, because it has a lower chance of being contaminated by skin organisms, particularly if you're performing a lumbar puncture. The other thing about tube 2 for micro, never refrigerate it. There are organisms like Naegleria, like Haemophilus influenza, like Neisseria meningitidis that cannot handle cold temperatures. And if they're in there, you'll kill them. So never refrigerate it. If you're doing molecular testing, you need to take an aliquot out of tube 2, and you need to do that first, because what we don't want to do is take tube 2, dip a few swabs, set up our culture plates, and then remove an aliquot for molecular testing. Higher rate of contamination if you do that. All right, so tube 3, maybe 4 is going to be your cell count differential, probably going to cytology or hematology, and then you may have a cytology tube, which is 4. In any case, when we get fluid into the laboratory, we work that up straight away. Very important to do so. And it's also important to be very specific about that specimen source. You need to specifically notate, is this from a lumbar puncture or is this from a shunt? Because knowing the location of where that fluid came from can have some very important clues that could be pertinent clinically as you go ahead and work that fluid up. Okay, so we've got our fluid for micro. We're working it up immediately. We don't refrigerate it. First thing to do, wet prep. Very important. Easiest test in the world. Put some on a slide and look at it. You're looking for motility. And this is particularly important if there is a concern for something like Naegleria. We'll come back to that in a little bit. And remember that white cells can also exhibit motility as well. So there are some things you need to keep in mind to be able to tell Naegleria from a white cell. When you're setting up your slides to do your various smears and stains, it's really recommended that you cytocentrifuge your spinal fluids because that will really increase the yield of what may be in that fluid. Now, in microbiology, of course, we're focused on organisms, but we know how to identify other things. So if you see on your smears unusual things that you're not quite sure what they are, like blast cells or something with atypical morphology or maybe even a neural tissue cell, you need to reach out to your cytology section or a pathologist to try to figure out what those findings actually mean. Nevertheless, you should report it. I see a number of blast cells, or I see cells with unusual morphology. All these things are important clues to help figure out what is going on. And especially with spinal fluids, if you see an organism or something, get a second set of eyes, phone a friend, ask to have a second read of your positives. It's very important. Sometimes these slides are very, very difficult to read, so it never hurts to get a second opinion. Okay, so now what do? Now, we've all experienced this with spinal fluid. Sometimes you just get drops, right? Here's an example of all the tests that you can order at my institution. There's a lot of stuff there. So we have a whole bunch of tests and very limited fluid. How do we prioritize what testing to do? And this can be a tough call. The first thing to do is have a conversation with the ordering provider. I have a limited amount of fluid. You have all these tests ordered. We've got to figure out the way forward here. And so even having that conversation can be very important and can really help clean down the test menu to what is important for that patient. If you are canceling tests off this massive menu, obviously you have to call the provider and inform them that you have to cancel certain tests. In any case, if at all possible, try to retain some residual sample of the spinal fluid because you may need to do repeat testing. You may need to send out for some referral testing. So try to have all of your bases covered. Okay, let's get to the good stuff. What is in the forest of spinal fluid? What should we normally see? So normally CSF is clear, should not be turbid at all. Sometimes it can get a little bit yellow. This is called xanthochromia. It could be due to a traumatic tap, or it could be due to something like high protein or bilirubin. You should see very few white cells and no red cells. This is in a normal spinal fluid. Normal spinal fluid is not turbid. So turbidity is defined for white cells as greater than 200 cells per microliter, for red cells greater than 400, and that will look like a frankly bloody tap. You may see neutrophils. So the center picture is a monocyte as well as a lymphocyte. And if you see cells like this, well, this could be indicative of a couple of things. If you see neutrophils, more often or not, that is associated with a infectious cause. Whereas if you see lymphocytes, this can be due to infection, but it also can be due to an underlying inflammatory cause of pathology. Nevertheless, if you see these types of things, you should report them. You're not quantitating them. That's for cytology or hematology to do. But we should call what we see. The bottom picture are blast cells. And again, these are atypical structures for spinal fluid, but if we see them, we should report them. This could be indicative of a lymphoma or a leukemia. And again, consult your pathologist or your cytology colleagues to see if you can figure out what this thing is that you see in your smears. Okay, now we're going to get more comfortable. So, findings of note. What are the important things that we would find in spinal fluid that need to be reported? Well, obviously, Streptococcus pneumoniae, the #1 cause of meningitis, but you also might see gram negatives like E. coli. Here's a good one that we shouldn't miss, Neisseria meningitidis. See all of those nice little gram negative diplococci. Important not only for patient care, but remember there's lots of other downstream infection control considerations that you need to keep in mind when you have a reported Neisseria meningitidis. You might see things like Listeria monocytogenes. Think about group B strep, especially in infants that are less than 2 months old. And of course, Staph aureus, which you often can find in shunt infections. So you need to be familiar with what is normal and what is abnormal, like we have here. Also, this is a good one. This was an Enterococcus aerogenes. Let's see if I can get my little mouse to work right there. So it likes to hide intracellularly. So try not to miss this one. What else could we find? Well, fungi. So here is a lovely Cryptococcus. This is a calcifluor white stain, and you can see how those yeast really pop out when you're using this stain. You see those large yeasts and small yeasts. That's characteristic for this particular species. And also you get a sense of the polysaccharide capsule around each of those cells because of the separation between all those cells. In a case of cryptococcal meningitis, sometimes the spinal fluid itself is going to be really sticky and viscous because of all that polysaccharide. Now, this is a fun one. We don't do India ink anymore, but it sure does make those yeasts show up, doesn't it? Another thing to consider are both hyaline and demodiaceous molds. Now, fungal meningitis is actually not very common. However, remember that in the past few years, we have had outbreaks due to contaminated epidural steroids, both with Fusarium solani as well as Esferohyalum. And so if you see fungal elements, again, get a second set of eyes to look at it. Don't discount it. It could be very important. And it often warrants a call to the provider to also recommend additional testing besides just doing fungal culture and smears. And of course, the one that we always are interested in seeing but kind of don't want to see, Naegleria fowleri. And so this is a nice picture of a Naegleria that I swiped from CDC. And you can see that we have the amoeboid structure. We have a very prominent nucleus and a vacuolated cytoplasm. And, it is possible to get these confused with white cells. The staining can look similar, but you do have to train your eye in order to differentiate Naegleria from the white cells. The other important thing is Naegleria will demonstrate directional movement. Okay, so communicating those CSF findings, obviously this is a critical value, and we need to communicate those as soon as possible to our providers. Be sure to get the read back. We have a 60-minute turnaround time for gram stains, which is incredibly important. If you see those other cells, PMNs, lymphocytes. You need to report those few, moderate, many. You need to do a semi-quantitation. Remember, other lab sections will be doing that absolute quantitation and differential, but it's important for us to call what we see because this is always an indicator of some sort of abnormal pathology. Important information for the clinical service. And of course, your gram stain report needs to be very specific. Have your gram stain reaction, your cellular morphology and arrangement, and any unusual findings that you see. So, for example, few gram-negative diplococci, intercellular, and moderate white cells. All right, now let's move on to BAL specimens. So for BALs, the goal here is to get a good sample from down deep in the lung because that is where the pathology is. So we're looking for cells and other soluble substances from the lining fluid of those distal airways. So the provider will use a bronchoscope. We'll run that tip down the trachea into the bronchi as deep into the lung as possible to even those third and fourth order bronchi, the really tiny ones. They'll instill up to 300 mils of sterile saline and aspirate it back out. And surprisingly, you can get about 70% of it back, which is important because we'll have a lot of fluid to work with. Okay, so just like our other body fluids, we're going to transport these at ambient temperature. We're going to process them as soon as we get them. In some cases with BALs, they can have a lot of proteinaceous material in them, and so they can be quite thick. They may have particulates. You may have to filter these before you can work with them. Always very important, if you have multiple specimens, work them up one at a time. You do not want to mix up your BALs. And of course, and this applies to all of our body fluids, work in a biosafety cabinet. So we're going to have a lot of fluid to work with, and we're going to split this between multiple lab sections. So cytology will get their aliquot. They'll be doing probably some flow cytometry. They'll be doing various cytospins and stains. They may do a differential and a CD4, CD8 count as well. For micro, we'll be getting our fluids. We'll be doing various smears, stains, looking for bacteria. Don't forget AFB as well as fungi. And we'll be setting up our cultures as well. And we will be performing molecular studies. Again, if you're doing molecular testing, take that first aliquot out of your micro aliquot and set that aside for your molecular testing. Okay, so prioritization of testing. Not as much of an issue with BAL because generally you're going to have a pretty healthy amount of material to work with. However, given this big test menu, it still might come up. And of course, you would want to talk through that with the provider if there are any other questions that arise. We talked about using an aliquot for molecular testing, set that aside. And again, reserve some other specimen in case you need to do repeat testing or have to do a send out. Okay, in case you were sleeping after dinner, here's your next question. You see the following thing on a BAL smear. What is it? Is it a lophthomonas? Ready? Is it ciliocytothoria? Is it an alveolar macrophage? Or is it a hairy B cell? Anybody brave enough to guess? Okay, I will tell you the answer. This is ciliocytothoria. It looks like it could be something, right? So this is actually the remnants of a ciliated epithelial cell normally found in the lung. Yeah, I apologize if that doesn't show up too well on the screen. It's a bit bright in here. So our first answer, lophthomonas. Lophthomonas is actually a protozoan that's found in the gut of cockroaches. However, the reason I'm bringing this up is that there were actually a series of papers that were published that indicated that lophthomonas was being found in human lungs. These two things are not the same. It was a misidentification. What we're looking at is Ciliocytothoria. Okay, what is in the forest of BAL? Well, remember, this is a very active metabolic fluid. So you're going to see lots of things as a baseline. There's lots of macrophages in a lung. Think about what it's doing. It's clearing out a lot of debris that we breathe in. So they're doing their job. There'll be a lot of them there. You'll often see lots of lymphocytes as well. You may see PMNs, you may see eosinophils and mast cells. If you are looking at a specimen from a smoker or a vapor, it may look like this. So this is an alveolar macrophage, but it has taken up the particulate material from smoking and vaping. So it gets very dark and you can see little particles, little inclusions in that macrophage. It's doing its job. You're also going to see our new friend, Ciliocytothoria. This is normal. It's not a pathogen. Now, of course, you may get a sample like this. So these are squamous epithelial cells. Large, square, very prominent nucleus. You can see how much larger they are than the rest of these cells. Here's another little remnant ciliated epithelial cell right there. But the issue here is that if you have a sample with a lot of squamous epithelial cells, this is a poor collection. This is not a true collection from down deep in the lung where the pathology is taking place. So your laboratory probably has some criteria indicating the acceptable cutoff for the numbers of squamous epithelial cells that are allowed in a specimen. Normally, if you have greater than 10 per low power field, those are samples you should reject. It's not worth working them up because they are not truly representative of what is going on in the lower respiratory tract. Okay, what interesting things might we see in BALs? Well, obviously lots of things. Gram-positive cocci, our friend Streptococcus pneumoniae. Now, this particular picture, this is a very overly colorized slide. However, you can still make this call based on those characteristic lance-shaped diplococci. Obviously, you can see a wide variety of G and B as well. Name one, and we've probably seen it in a BAL. But you can also see more unusual things like nocardia, so filamentous, kind of finely beaded, somewhat gram variable filaments. And of course, our favorite, Matthew's favorite, AFP. So a nice hot pink pinion with some cording going on. But we can also see other interesting things too. Fungal elements. So this is actually a picture of an aspergilloma. Well, excuse me. This is actually a tissue section giving you a sense of how those fungi kind of ball up and coalesce together. But you can see fungal elements all the time on a BAL specimen. Don't discount them. You can also see things like Pneumocystis girevettii. Note those very prominent, this is a calcifluor white stain, but those prominent double-lobed nuclei, very characteristic of this. And finally, we can see more unusual things. This is a Strongyloides stercoralis that showed up on a gram stain. Now, there's going to be quite a size differential because these are larger. And what's interesting here is that, first of all, it showed up so well on the gram stain. We went back and looked at the original specimen, and we could pick up motility on our wet prep. So this was a hyperinfection with Strongyloides. All right, again, anything in a BAL, this is going to be a critical value. And of course, every institution will have its own critical value list, so be sure to work all off of your SOP. We notify the providers within 60 minutes of the result generation. Very important with BALs to specifically note where that sample came from. Was it a right upper lobe, a left lower lobe? The cell type and morphology is critical, as well as the cell composition. So if you see things like lymphocytes or a predominance of neutrophils or other inflammatory cells, report those. Remember, cytology is going to be doing quantitation, but we need to call what we see. Of course, if there are a predominance of squamous epithelial cells that exceed your collection requirements, that needs to be reported back to the provider. And also to let them know that this sample is unsuitable for further workup and perhaps a recollection should be considered. And of course, any additional comments to cover unusual morphologies should be included on the test report as well. All right, cruising through this, next we'll talk about peritoneal fluids. So peritoneal collection usually starts with running a catheter into the left lower quadrant of the abdomen, and this is done with ultrasound guidance. And so we do this for a couple of different reasons. It could be diagnostic because we have a patient who has a peritoneal fluid collection. Perhaps they have a focus of infection somewhere, or perhaps they have spontaneous bacterial peritonitis, which we will talk more about. So there's a diagnostic need. There's also situations where there's a therapeutic need. Obviously, patients who have peritoneal fluid buildup, it's very uncomfortable, right? And so by drawing off that fluid, it often relieves their symptoms. It may not address the underlying cause of that pathology, but it certainly makes them more comfortable. So those are a couple of reasons why one would do a peritoneal tap. When we get this fluid, we're often going to get a pretty healthy amount. So there will be enough to go around, and we do have to split it between several laboratory sections. So some will be going to chemistry for their total proteins or glucose testing. Some will go to hematology for cell counts as well as cytology. We in micro will get quite a bit as well. And there may even be some fluid going out to a reference lab. So we're going to have to split it all up. So prioritizing the testing, again, probably not as big of an issue here, although there's a pretty healthy menu to choose from. And so if you do have a situation where you have to make some choices, again, have that conversation with the provider. They really do appreciate getting a call from the lab and asking how to proceed best for the patient. All right, next question. What is the most common organism associated with spontaneous bacterial peritonitis? Is it, and you can raise your hands if you're brave, Klebsiella oxytoca, Pseudomonas aeruginosa, Group A strep, E. coli, or Clostridium perfringens? Okay, we're going to come back to that. It is E. coli. So some of you guessed right. All right, what is in the forest of peritoneal fluid? And there can be a lot of things going on here. But primarily, the first test that's done is the determination of what we call the serum acidic albumin gradient. And simply put, this is the concentration of albumin in the serum minus the concentration of the albumin in the ascites fluid. We do this in order to classify the fluid as what we call a transudate or an exudate. And this is important because knowing what kind of fluid it is can kind of lead us down a potential diagnostic path. So our transudative fluids, they tend to be mostly clear. Sometimes they're a little bit yellow. These can be due to hepatic cirrhosis or portal vein thrombosis or even alcoholic hepatitis. They have a higher level of albumin, greater than 1.1 gram per deciliter. Now our exudates tend to be more cloudy, more turbid, more often associated with infectious processes. They actually have a lower level of albumin in them, but they can also be associated with things like intestinal obstruction. Obviously, sometimes we get some bloody peritoneal fluids, and this can be due to a traumatic tap, obviously, but it also could be due to things like TB or even malignancy. And finally, we have what are called our milky fluids. So this is a chylous or pseudochylous effusion. And you can see that it almost looks like milk. And this is actually due to a blockage of the lymphatic flow. But it can also be due to things like TB or carcinoma or even granulomatous disease. So very important, the first thing you do when you get that fluid, look at it. Figure out what those characteristics might be. All right, what might we find in peritoneal fluids? Well, lots of things are in peritoneal fluids. And, if we're thinking about infection, well, certainly this can be due to structural abnormalities. There's a drain in place, there's a fistula, or there might be trauma. And we can have infections with lots of different things. Here's a picture of Bacteroides fragilis, so don't forget about the anaerobes. So we have these nice, long, sometimes they're a little bit spindle-shaped, gram-negative rods, often vacuolated. Most of the time, generally, around 90% of the time, we have monomicrobial peritoneal infections. But sometimes we have these polymicrobial infections, and they can be quite messy. In this particular picture, there is a whole lot going on. We have some Bacteroides fragilis here. We have some Enterobacter cloacae here. We have sort of a background of E. coli. And we have lots of Enterococcus faecium here, 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 and here. So these peritoneal polymicrobial infections can be quite messy. They can be very difficult to treat. Okay. So I want to talk about an interesting case that we encountered earlier this year. We didn't see the case at our institution, but we were asked to comment about it. So this is a 72-year-old female. She's got uncontrolled diabetes. She's got urinary frequency, vaginal discharge, proteinuria, and moderate hematuria. And this has been going on for about 2 months. Okay. Her urine culture is negative, of course. And she was given an empiric course of both antimicrobials as well as antifungals, which didn't really improve anything. She had some imaging done. She's got no abnormal anatomy. She's got no obstruction, so couldn't really come up with a focus of infection. But what was odd is that she had this incredibly milky urine. That's her urine sample. And so in the morning, it would start out fairly clear, normal looking. And as the day progressed, it got more and more milky. So this is chyluria. Anybody would want to venture a guess what this might be? You'll never guess, so I'll tell you. This was an infection with Wuchereria bancrofti, a filarial infection. And this was actually, the urine was smear negative, imaging was negative, but unfortunately they didn't perform any serology on this particular patient, which might have sealed the deal. The reason they decided it was Wuchereria is that she did have a remote history of residence in the Dominican Republic and Puerto Rico. And that had been years ago. So this had been indolent for quite some time. She was treated with empiric doxycycline because doxycycline will affect the obligate endosymbiont Wolbachia bacteria that lives inside of the Wuchereria. So you wipe out the Wolbachia, the Wuchereria will die eventually. And so this was a really interesting case. I hadn't really thought about filaria and chyluria for a very long time. So I did learn something this year. All right, coming back to spontaneous bacterial peritonitis. And so this is an infection of the peritoneal fluid without a clear focus of infection in the abdomen. The patients will be acutely ill. They'll have fever, abdominal pain. They'll often have a very septic presentation with altered mental status. The mortality from SBP is significant, up to 70% in adults, particularly those with underlying cirrhosis. And the danger signal here is the absolute neutrophil count. If it's greater than 250 cells, then those individuals run a very, very high risk of mortality. The most common causes of SBP are E. coli, strep viridans, as well as Klebsiella pneumonia. Now, what we do know is that if you perform paracentesis on these individuals, so draw that peritoneal fluid out, you can significantly affect mortality, reduce mortality. Every hour you delay paracentesis, your mortality goes up by 3.3%. So again, this underscores the reason for getting those fluids to the laboratory quickly and working them up quickly, because the clock is on. Now, we do know that the gram stain can be relatively insensitive for detection of SBP, because there's often a lot of inflammatory cells in there. It makes those smears hard to read. So in order to get recovery for culture, it's often recommended that the best practice is to inoculate blood culture broth bottles with peritoneal fluid. The issue, though, is that you need to have validated your blood culture broth bottles for that particular purpose, assuming that you get blood culture broth bottles, but that's a different story. This is an off-label use of blood culture broth bottles. So again, you do need to validate that if you're going to use it, but it does work pretty well. All right, interesting other findings in peritoneal fluids. Well, obviously we can see different fungi, yeast as well as molds. Here's a nice Candida albicans for you with lots of hyphae and pseudohyphae. And we can actually have what we call spontaneous fungal peritonitis. And this can happen between 3 and 6% of all cases of peritonitis. The mortality from SFP is also very significant. Don't forget about our friends, the parasites. You can see a number of different parasites in peritoneal fluid. Things like Anaerobius formicularis, or entamoeba, or Toxocara. Here is a wonderful picture of an Echinococcus granulosus. You can see these very characteristic hooklets that we saw in the peritoneal fluid. That was a fun day in the lab, I think. Okay, we communicate those findings because they are part of our critical values policy. You'll want to check your institution's critical value policy. We want to call the fluid by the proper anatomic term. It's not ascites, it's not paracentesis, it's peritoneal fluid. Remember, the first thing we want to do is when we get our specimens in the lab, look at it. What's the color of it? What's the clarity of it? Your nucleated cell counts and red cell counts, that's going to be done in another lab section. But if you see certain structures on your smears, you report them. Call what you see. We all have good eyes here. Okay, so now let's talk about synovial fluid. So I picked a tree with lots of different joints in it. All right, synovial fluid. This is the fluid that's coming out of your joint. You collect this via arthrocentesis. If you've never had one, let me tell you, it's big fun. You're looking for the fluid that is filling the joint. So it has lots of important functions, kind of like spinal fluid. So it's a source of nutrition for the interior of the joint, all of the cartilage that's in there. It removes metabolic waste. It also has hyaluronic acid. And that's important because it's very viscous and it serves as a cushion for your joint, which you're going to want to have when you get older. The problem with synovial fluid is you're not going to get much. Unless there's a very large effusion, you're not going to get a whole lot of synovial fluid out of a joint. Because of that, what we do with this fluid is very critical. It is an irretrievable specimen. We must handle it carefully and in a timely fashion. Sterile technique, always a must. So we'll probably get 3 tubes. The first tube It's a plain sterile tube that will go to chemistry for their analyses. Tube number 2, probably a green top, a heparin tube, that will come to micro. So we'll have hopefully enough material to set up our cultures or whatever testing that has been ordered. And then we might even get a third tube, an EDTA tube, for additional microscopy. Again, it has been shown that inoculating synovial fluid into blood culture bottles can improve the yield, particularly when you're looking for cultures of unusual organisms. The problem here, though, is that, yes, you should have validated your bottles for that use, but this is a really hard validation to do because you're just not going to get much specimen to work with. So, you know, it is a best case scenario if you can do that, but if you can't, we still have more conventional culture methods as well. Okay, again, drops of volume. There won't be a lot to work with. Sometimes you will get a call from the service and they'll be asking, can't we just send you a swab? No, just say no. Swabs do not provide sufficient volume for testing of synovial fluids. Plus, they are unsuitable if you're going to do any kind of downstream molecular or sequencing on that particular fluid. So the recommended tests for the limited volume that you're going to get, first, color and clarity. Well, that's easy. All you have to do is look at it. You're not going to lose any volume that way. A total and a differential leukocyte count should be done. Again, that's going to be a cytology or hematology task. We will get gram stain and culture for bacteria. There may be a request for fungal smears and AFB smears as well. And there should be an examination for crystals. That will probably be done in another lab section. Although if we in micro see a crystal, we should say, hey, we see a crystal. We'll talk more about that in a minute. Other tests that could be done on synovial fluid, if you've got the volume, this is where our non-bacterial organisms come in, our fungal smears, AFB smears, and culture as well. Pathogen PCR might be considered, or other things like complement assays or uric acid assays. So again, the conversation about prioritizing testing may very well come up. All right, what do we see in normal synovial fluid? Well, again, this is a fluid that a lot of things are taking place in. So there's going to be a lot of background, and that's fine. It's normal. Normally, synovial fluid is clear. Sometimes it's a little bit yellow. There will be a number of nucleated cells that are normally in synovial fluid. So you can see the percentage of each of these cells down here: neutrophils, lymphocytes, monos, synovial sites, so cells from the synovial surfaces inside that joint. You may even see occasional red cells. That's normal. One thing that's very important is the viscosity of the fluid. So I talked a bit about the hyaluronic acid, you know, providing viscosity and a cushioning aspect. So one way to measure viscosity, and I know it's a little bit hard to see on this picture, is that if you dripped some of the fluid from a syringe into a tube, if it's viscous, it's going to form a thread coming out of the syringe, whereas an abnormal fluid will fall in discrete drops because it doesn't have the hyaluronic acid, it's not viscous. All right, so again, this is normal synovial fluid. You'll see things like neutrophils and lymphocytes and monocytes and even synovial cells as well. That's all normal. You may see autolytic neutrophils. They're doing their job in the joint. They're cleaning out any cellular debris. So you should see these. What you shouldn't see, though, is an abundance of neutrophils. So this is neutrophilic pleocytosis. If you see a picture like this, then obviously there is some abnormal pathology going on inside of that joint. So when we get fluid in the lab, the first thing that we should do is look at it. Again, the color and the clarity are important. And we can classify our synovial fluids by doing this. A normal fluid won't have much color to it. Clear, maybe a little bit of a yellow tinge. So this fluid is a little bit more yellow. It is still clear though. This is a non-inflammatory fluid. And this could be associated with certain types of arthritis, but it's not severe yet. This obviously is a bloody fluid. It's an example of hemarthrosis. So there's blood in the fluid. There may be bleeding in the joint. In most cases, the hyaluronic acid is starting to break down. You're not going to have a very viscous fluid. And then finally, this last one is a frankly septic fluid. It's yellow, sometimes it's even brown, it's turbid, it's very, very thin because it is not viscous at all. So these are the characteristics that you need to look at macroscopically in order to help classify that fluid. And again, all of these things are very important diagnostic clues. Okay, what are the trees in our forest of synovial fluid? Well, first of all, the gram stain is really not a great test. It's only about 50% sensitive. And so that reinforces that concept of if you were to see something, phone a friend, have a second set of eyes on that specimen to inspect it and see if they see what you think you see. You may see things like this. These are calcium pyrophosphate crystals. This is from a case of osteoarthritis. So you can see these elongated crystals and a lot of them. That's not normal. That shouldn't be there. Obviously, lots of different bacteria that you can see in an infected synovial fluid. This happens to be Clostridium perfringens. So we have our nice big fat gram-positive rods. Oh, here's a good one. Gram-negative diplococci, Neisseria gonorrhea. You can also see unusual things like nocardia. This is a nocardia pseudobrasiliensis that we saw in a joint fluid. So again, long, thin filaments, beaded, gram variability sometimes. This is not a case that we saw. I pulled this from the literature, but I thought it was really interesting. What do you think this is? Oh, sorry. This here? Oh. Well, that is kind of crummy. So, top left, one with all the arrows. Hot pink rods. AFB, say it, you can say it. This was actually a case of Mycobacterium leprae. And so this is from a synovial fluids that were drawn from the interphalangeal joints. So that was, yeah, exactly. So it's good. So everything is referenced. So you can go and look this paper up. It's pretty interesting. And then finally, think about fungi. This is Coccidioides immitis. Those are the spherules. I'm really annoyed that this pointer is not working. Obviously, you can see the spherules. This was from an elbow joint, of all things. Okay. So, communicating the findings, obviously incredibly important. Again, this will probably be covered in your critical values policy. Very important to note where that fluid came from. What joint was it? And also notate the laterality, left or right. The first thing you'll do when you get the fluid is you're going to look at it. Color, clarity, any kind of particulates that you can see macroscopically, that needs to be part of your result report. If you're looking at smears and you see crystals, crystal analysis is going to be done by your cytologist. But you can see crystals. If you see crystals, say, hey, I see crystals. You may not have to identify them, but it's also important to tell your other section to say, hey, I see crystals. Please take a closer look at them. Erythrocyte counts, nucleated cell counts, and differentials. That's going to be done by a different lab section, but make sure that they get done. Where micro comes in, obviously, because we're special, we have those special morphologic findings. So what do you see on the gram stain? Hopefully you'll have enough fluid to be able to set up your cultures, do your AFB smears and cultures if ordered, and fungal smears if that's ordered as well. All right. I wanted to throw in a couple of slides about formalin-fixed paraffin-embedded cytology because I thought this was a really interesting technique, and this helps us get into the really dense jungle. So what this is, it's sort of, it's simple and ingenious. And so basically, we are taking a fluid sample, we're going to centrifuge it into a pellet. To that pellet, you add something like thrombin, or there are some commercial agar-based materials. You're going to form a solid pellet out of your former liquid cell pellet. Then you're going to take that solid pellet, formalin fix it, and embed it into paraffin, just like we were performing histopathology on a biopsy of a tissue section. The beauty of this technique is that you can concentrate whatever's in your body fluid, but you can really preserve quite nicely the cellularity of the material as well as the architecture of those cells. And that can be very, very important. So we have a tissue block and we can put it on a microtome and make sections like we would for pathology. And we take all of these sections and then you can put it on a slide and do whatever stains you want. So in a sense, this also gives you a way to stretch the very small cell pellet that you have. Obviously, you'll have lots of sections available for lots of different stains. And so this can be a huge advantage when you have very small amount of material to begin with. The downside, of course, is that, well, once you do this, you can't do culture. And if you're going to do any kind of molecular testing, PCR out of paraffin blocks tends to have a very, very low yield. So that's a downside as well. But I just wanted to bring this up because I thought it was a technique. I didn't know a whole lot about it, but I thought it was really interesting once I learned more about it. All right, your favorite slide, because this is the summary slide. We're going to wrap it up now. Remember, we talked about the pre-analytic steps, the packaging and the transport. One thing I failed to mention in the beginning is that when you look at all those analytic steps, look at them and make sure that what you have down on your SOPs actually agrees with what is happening on the bench in the lab. It's always a bad day when you find out that my SOP says A and my bench is doing Z. So it pays to go through on a regular basis and try to correlate your SOPs to what is actually taking place. All right, spinal fluids. We collect these carefully and process them because they're irretrievable for the most part. Never refrigerate them for micro. And your critical values are going to include things like your gram stain reactions or morphology and other structures like PMNs. Your BALs, we process these as soon as we get them. You should have rejection criteria, especially when it comes to SECs. Be aware that there's a lot of normal morphology in a BAL. We saw a lot of things in that for us, didn't we? You're going to do testing for bacteria, AFB, fungal, and don't forget the parasites. For our peritoneal fluids, first of all, look at that fluid. What's its color? What's its clarity? Lots of different tests that could be ordered. Keep in mind, spontaneous bacterial peritonitis with its very high chance of mortality. So again, work those fluids up immediately when you get them. If you've validated your blood culture broth bottles, that's a good way to recover organisms out of peritoneal fluids, and E. coli is the most common cause of SBP. For our synovial fluids, may not have a whole lot to work with. So again, work with these carefully. You might want to consider inoculating blood culture broth bottles if you have validated for that particular purpose. And if you do find something on your smears, look at those smears carefully and get a second read of those positives. And for FFPE cytology, an interesting technique, go back and find out if your pathology section is doing this. Works on lots of different fluid types, but it's great for preserving cell morphology. So with that, thank you and happy collecting. They sent us a spoon, I swear. It's so nice of them. And so I think we have some time for questions if anybody has any.
Thank you, Dr. Hata. Any questions here in the room? Yes.
So when you were talking about spinal fluids, so do you routinely do wet preps on every spinal fluid, or do you have criteria?
We do wet prep on everything.
Really? Okay.
Yep.
How often do you pick up Naegleria?
Never,
Okay.
but I mean, we live in a Naegleria area.
We do.
You know, and I think that's the one, yes, the one thing that I think, you know, our inner microbiologist really wants to see one, but I've never seen one personally, but I know they're out there.
Okay, cool. Thanks.
With that question, she stole my question. Have you seen anything abnormal though in the wet preps for the CSFs that you've shared?
Not really. More often it's, oh, I think, you know, and this will be another service saying, oh, we think we see something moving, take a look at it. And it turns out to be a white cell.
Okay.
But the ruling out is as important as ruling something in.
Sure. Okay. Thank you. Any questions, additional questions in the room, in the chat?
Just that Diane said that it's just a real practical talk for microbiologists, and especially, you know, for us state people, we don't really get to, you know, see when the fluids come right to us. So it is interesting to hear.
Any other questions? Okay, we're all going to stay warm tonight, right? Well, thank you, Dr. Hata. That was excellent for helping us get a greater appreciation for the forest we are faced with on a daily and for nature in general. Those were all very pretty pictures. So thank you to everyone for joining us tonight in person and virtually. And again, thank you to Matt and Dia Soren for your support of the JAM community. Again, speaker selections were considered with all of you in mind, so please share topics with us for next year as they come to mind. Email is best, but feel free to share verbally as well. Our next meeting is not until March 4th at Baptist downtown with the topic of HIV presented by Dr. Jason Wilson. For information on the rest of the schedule, please visit the JAM website, www.jamsociety.net. We welcome new members any time of the year. You can join or renew online with Matthew and send me any member highlights that you want to share. And we hope to see you all there at the First Coast Symposium, February 7th through 8th. Invite all of your friends and colleagues, and drive safe and stay warm. Thank you for coming.
Thank you.